Now I invite Dr. Anne. Dr. Anne, she's a consultant, senior consultant in Department of Oculoplasty, Little Flower Hospital. She'll be talking about the masquerades.
Good morning, everyone. I'll be talking about masquerades of dacryocystitis. So far, we are talking about DCR and dacryocystitis. Dacryocystitis is a common cause of watering, characterized by epiphora, pain, discharge, and swelling. So the sac is situated below the medial canthal tendon insertion. The definitive management is dacryocystorhinostomy. So being in a tertiary eye care center, we get a lot of references for DCR. So do all cases needs DCR? So I'll be sharing few of my experiences. This girl came with a swelling at the medial canthal area, 2 weeks duration. She had occasional watering, but it was not her chief complaint, and it was Rho plus was negative, and there was regurgitation of fluid through opposite punctum while syringing, but it was not fully blocked also. So I did an imaging and found there is a mass at the sac area. So because of the clinical history and the examination findings were not matching, I had a doubt whether to go with DCR or not. So I discussed the situation with the patient and posted her for exploration of the mass plus or minus DCR. But in between, patient went to an ENT surgeon and did the endoscopic DCR, but the mass was persisting. So next option is anyway external approach. So when I opened it, I found that there is a mass, friable mass with indefinite borders, and sent it for histopathological examination. It came as extranodal marginal zone lymphoma, which is a low-grade lymphoma, and the patient was sent for an oncology department. So in between, the size increased in size, and we could see that the mass was spreading inferiorly, and it was going lateral part of the orbit also. So repeat CT scan was done and biopsy was taken, and the report came as diffuse large B-cell lymphoma. It is an aggressive grade lymphoma, and chemotherapy and radiation was needed. When I saw the patient last, the patient is in remission. So a low-grade lymphoma can transform to a high-grade aggressive variety. The next case is a 59-year-old male, came with swelling 2 months duration, and he had a history of DCR 2 months back at a peripheral center, and now he came with a large fungating mass with surface ulceration. Obviously it was not benign, and CT scan confirmed the mass at the sac. Mass excision was done, and the tumor was extending to the nasal cavity via the DCR ostium, and the borders were positive, and the diagnosis was well differentiated squamous cell carcinoma, and the borders were positive. Again, oncology consultation was done. They did a wide excision and reconstruction, and adjuvant radiotherapy was given to this patient. So if you suspect a sac tumor, if it is confined to the sac and if it is benign, you can do DCT, dacryocystectomy. And if you have already opened the sac, deep incision biopsy should be done during DCR if suspicious, and never manipulate the lacrimal fossa because it can spread to the uninvolved nasal cavity also. And about DCR till you get a HP histopathology report. This lady is a 71-year-old female, came with swelling right eye 6 months of duration. It was a soft cystic swelling, and it was gradually increasing in size. There was no history of watering. Again referred for dacryocystitis, but syringing was free. So I went ahead and explored it. So there was a cystic mass with a mucopurulent content inside, and this lesion was going inferiorly and medially. I traced it as far as I could, and I excised it. The histopathology report came as infected cyst wall aligned with respiratory mucosa. ENT consultation was done, but they advised follow-up as the patient was asymptomatic that period. So mucosals it is caused due to the blockage of the natural ostium. There will be accumulation of secretions, and enlargement causes bone erosion. Again, this patient, he had a swelling 2 years of duration, and there was no watering, and this mass was well below the sac area. I thought it was a parasitic mass, excised it, but it came as pleomorphic adenoma of the lacrimal gland. So I was a bit surprised and rang up the pathologist again, but she was sure that it was pleomorphic adenoma of the lacrimal gland, but the site is not characteristic of lacrimal gland. So then I referred, then pleomorphic adenoma of the ectopic lacrimal gland has been reported, but it is very rare, only 10 cases I could find. And after 1 year, the patient is symptom-free, doing fine. This patient, he is a Bengali worker, 20-year-old male, came with blood-stained watering in right eye, along with epistasis. Again, syringing was patent, and CT scan showed some irregular mass in the sac area. Because he was complaining of epistasis, I referred for a ENT consultation. Then the ENT surgeon told that the nasal mucosa is involved with rhinosporidiosis. These are the white spores of the rhinosporidium. So it was a case of nasolacrimal rhinosporidiosis. It is a chronic granulomatous infection of the mucous membrane, and it is an aquatic protestant parasite. And patients almost give the history of pond bathing, and this patient also had that. And it can infect conjunctiva and lacrimal apparatus. Local surgical excision and coagulation is the treatment, and medical management is with Dapsone. This patient came to me with a reference of dacryocystitis, but it was a general practitioner, not an ophthalmologist. He came with a swelling of left eye 1 month duration, and the mass was extending well above the medial canthal tendon insertion. Syringing was patent. He had no complaints of watering, and you can see a infected hair follicle there. It was a furuncle, and it was subsided with a course of systemic antibiotics and analgesics. Again, this case came with watering discharge, and there was a pouting punctum, and there is a swelling medial to the punctum in the canaliculus. On expression, I got concretion. So it is a canaliculitis. It is caused by organism Actinomyces israeli. Some few other fungal and viral infections are also can cause this. So treatment is canaliculotomy and curettage and topical antibiotics. So when you see a chronic unilateral conjunctivitis, it should raise the suspicion of canaliculitis also. These two cases, one was a young male, and another case was a elderly lady. Both came with a history of recurrent periorbital edema, swelling, and there was no pain. Again, there was no lacrimal apparatus obstruction. And when the edema subsided with the anti-inflammatory measures, these two masses was persisting below the medial canthus. And it was a firm mass, and on exploration, I got a rubbery mass, firm in consistency with irregular borders, and both came positive for dilophilaria. So dirophilaria repens is most commonly seen in our population. It is a parasitic zoonosis and endemic in our country. The presenting complaint will be initial inflammatory reaction, periorbital edema, and mass. There won't be any pain. And you can treat it medically with antihelminthics and steroids for an extent, but surgical excision is more easy. And if you want to identify the strain, PCR testing is necessary. So to summarize, inferomedial orbital masses may or may not have epiphora. Direct involvement of the sac or mechanical effect on the sac can be the cause. So it can range from benign skin conditions to malignant lesions. And while doing surgery, take care not to avoid sac and canaliculus. And there are many differentials reported. Careful history taking and clinical examination and probing, syringing, imaging can save you. Thank you for your kind attention.
Thank you, Dr. Anne, for masquerades of lacrimal sac.